We are so glad you're here. And these are three of my very favorite people. Nicole Piemonte, Lizzy, Rizk, and Tom Gillespie. And many of you already know them. You've been in classes with them, or they have taught classes with you. Or even if you are not here in Phoenix, I'm sure that you have had contact with them. So please welcome, who's going to be first? Nicole. Okay, please welcome Dr. Piemonte, and I'll let them take it from here.
Thank you. Thanks so much. Thank you, Dr. Seaman. Really appreciate it. So just by way of introduction, Dr. Gillespie, he is our Assistant Dean of Medical Education. He is the Academic Chair for Surgery and a Professor of Surgery here at Creighton. I am an Associate Dean of Faculty Leadership and a Associate Professor of Medical Humanities. And Lizzy Rizk, who is a third-year medical student. She has really important leadership roles within the School of Medicine, and she says she also loves the medical humanities. So that is by way of introduction. We are grateful to be here. So we're going to be talking a bit about, as the title indicates, permission to grieve. So really this is permission to kind of feel, express, and talk about emotions in medicine. It's something historically we've not been very good at in medicine. And so we're going to talk about the virtues and values of being able to do that and kind of normalize vulnerability and compassion in medicine. My clicker's not working at the moment, so 1 second. Perfect. It's this. Not working. Okay. I love this quote from C.S. Lewis. I've learned now that while those who speak about one's miseries usually hurt, those who keep silent hurt more. Silence has been normalized a lot in medicine and medical education. And even if we don't articulate what's going on, it's still there and it still catches up to you. So we want to model a little bit about what this looks like, about being able to articulate some of the real joys, but also the pain that happens in medicine and medical education. And the beginning of this for us starts with Lizzy sharing a story about her own experience, both in her personal life and how that inevitably bled into her professional and student life here at Creighton, and that will eventually involve Dr. Gillespie. And so I want to invite Lizzy up here to share her story.
Thank you, Dr. Piemonte. Thank you, everybody. Thank you so much for being here. Thank you those on Zoom for joining us. And like Dr. Piemonte said, the title was Permission to Grieve Post-Traumatic Growth in Medicine, right? So like those are really big words. What are we talking about here? And I really hope to just capture that by just starting by telling you a story. And I'm going to tell you a story about one of my dear friends, Nate. So I want to point him out here. This is Nate. For the people on Zoom, I'll use my mouse. It doesn't work. He's the person standing next to me on the beach photo. So Nate and I went to college together. We went to a school called Franciscan University, and at Franciscan University, something we focused really heavily on was like service and outreach. It was one of the reasons I really loved Creighton. It was one of the reasons I chose Creighton. And Nate just had this beautiful gift and passion for service and outreach work. And so these photos are actually us on a hurricane relief trip in Florida. That was like where I got to know him best. And then we became really good friends all through college. And I just remember being really in awe of the way that he served the people in front of him. And I remember him talking to me about some people that were really suffering in his life at a time. And I was just like, wow, Nate, that must be super hard, for you to carry that as well. And he said, no, Lizzy, what a gift it is to journey with people. And I think that just really emulates the kind of person that he was. He was just like one of the most beautiful souls that I've ever encountered, truly. So this is Nate and his beautiful wife, Mari. They got married about a year ago. And I met Mari at Franciscan as well. They're this incredible couple. And I just remember being so happy for them on their wedding day. Two incredible people finding each other, falling in love. And I was in my first or second year of medical school at the time. And I remember packing up my stuff, and I was just about to head out the door. And I received a text on a college group chat that Nate had tragically passed away 2 days after his wedding on his honeymoon in a water skiing accident. And I just remember being so shocked at the time at the fragility of life and just being so shocked and devastated by the loss of this beautiful life. Right? Like, this is like, I mean, their story has been all over the news. It is just such a terrible tragedy. Like, who loses someone 2 days after they get married, right? Just absolutely horrible. And I just so happened to be packing up to walk out the door to go give a talk on mental health in medical school to M1s. So the irony of that and the timing of it, and then just as all of us experience, I'm sure every single one of you can relate to this. Like, I just got swept away by the busyness of medical school. I just experienced the terrible loss of a dear friend, but then I walked out, I gave a presentation. 2 days later, I left to present at a conference. 3 days later after that, I was taking a final exam, and then it was the holidays. And I just like never really had time to think about truly the impact of the loss of this friend. And I just remember feeling super disconnected. I remember feeling really just not like myself, burnt out, but it was different. I just was kind of apathetic. Like, I couldn't really invest in my work. I couldn't really invest in the people around me, and I couldn't really put a finger on why. So fast forward, January was Nate's birthday, and his wife posted this video of him kind of as a like just memorializing him and honoring him on his birthday. And at the end of that video was this photo. And Nate's wife had announced that she was pregnant after their honeymoon. Just like this beautiful roller coaster of emotions, right? This terrible loss, and then this gift of new life. And his parents, he was an only child. So Mari, his wife, actually moved in with his parents. So just like so many emotions, right? There's just like so much loss, but then there's also joy. And I remember this was January, and I was just like feeling all of these things, but also like being so caught up in the busyness and stuff coming up and all of these things. And I went to sit down at a Gold Track leadership session with Dr. Gillespie. And Dr. Gillespie got up in front of us. And typically at our leadership Gold Track sessions, we talk about practical skills in leadership or tools or different types of leadership. And so we watched really cool movie clips. And so I was really excited for all of those things. I sat down, but Dr. Gillespie surprised me that day, surprised all of us. He ended up, instead of doing our stuff like what we would typically expect in our leadership curriculum, he shared a story about himself. And in that story, he talked about his own suffering and an experience that was really difficult for him, and how that impacted his leadership, how it impacted the way he served those around him, how it impacted his patients and colleagues. And I was just really moved by that in that moment. I was really moved by his vulnerability. So I went up after class really just to say thank you. And I went up and I said, Dr. Gillespie, thank you so much for sharing your story. That was really, really meaningful and like very impactful to me, and I'm sure the entire class. And we chatted for a little bit, and he looked at me and he said, Lizzy, are you okay? And I said, yeah, I'm fine. What are you talking about? He goes, no, really, are you okay? You don't seem like your normal self. And I said, well, I lost a friend recently, and it was just his birthday, and it's been like a really hard month, and his wife announced that she was pregnant, and it's like, I'm just trying to be strong, and I'm just trying to get through this, and I have so much to do, and like, it's like, yeah, the loss is terrible, but like, what a beautiful miracle that he's pregnant. And he just paused me, and he said, Lizzy, do you want to tell them what you told me?
Story a little different. While you were telling me this story, you were telling me the story about all the strong women in your life and how they kept telling you how beautiful this is and how wonderful this is. And this is something to be grateful for. And this is beautiful. And you're a strong woman. And you were telling me about your culture, women in your culture, and what the definition of a strong woman in your culture is. That You should look at the positive. But both were true. Both were true. This was a horrible, horrible thing that happened and a wonderful thing that happened. It's a very non-dualistic way of looking at it. The truth wasn't in the middle. The truth were both were true, but you weren't giving yourself permission to grieve. But the hard part, I think, and I think there are two people who have been on this journey with me. I see them in the room from when it was very raw. The hard part is leaning into the risk, right? Because it's one thing, you know. So I have learned that if I want to be a relational, authentic leader, that there's this level of vulnerability that you need to share, but that's fraught. If you are too vulnerable, right? Are you really a leader? But at the same time, if you're not vulnerable, are you really a leader? So I've decided to thread the needle on this, but I'm looking at Lizzy. I don't really know her that well. I mean, I know who she is, but this is a medical student, right? Boundaries, right? I mean, how much do you really get in? And trust me, boundaries do get crossed, and it's not good for the student. It's not good for the student because when you are the leader, you can't become too enmeshed in your students. But there's enough enmeshing that's good. And so I'm sitting there watching you, and I'm like, do I take the leap and name her emotion? And I did. And as we were going through this, I just want to tell another story how I learned this. I mean, I did learn it through my own grief and suffering, and I learned it through my own recovery. But I remember there was this family, and this is why you should always be curious as a healthcare provider. Just always be curious. And then I'm going to give the mic back. I thought about this on my morning meditation today. There was this family, this beautiful family. They had two children. Both of them were in the back seat. Both were in car seats. Somebody rear-ended them. Both kids end up in the trauma bay. This is when St. Joseph's Pediatric Trauma Center. And I'm running what I call bilateral codes. I'm literally running two codes. Both anesthesia are in the OR. We are closed to trauma. I call pediatrics. They're putting a kid on ECMO. And I'm like, I need you down here now. And I had to intubate this 14-month-old. We've all heard about it. We've all read about it. We know what the board is. We know about the little finger. We know about the cuff. You get one shot to intubate a kid. I'm going to be fast because I know I can talk too much, but you get one shot to intubate a kid. And the rule is the best person in the room, you ventilate them until the best person in the room is there. And there was no better person than me. So if you've ever felt like an imposter, trust me, as a trauma surgeon intubating a 14-month-old, I felt like I was an imposter. Oh, I had just adopted a 14-month-old kid. So all I could see was her face. And I did. And I remember my knees basically, and it was good. It worked out. But the sad part about it is that child ended up dying. And because of a head injury, and the other child lived. And I'm a trauma surgeon. There's not a lot of follow through. But like a year later, the family came to visit me. I'm like, why are they here? And the wife was grieving, and the husband was telling her, you have so much to live for. And they were not connected here. And that's what I saw. And I asked, and she said, I am grateful this kid is alive, but I almost wish she was dead. Because if she was dead, I could feel as bad as I want to feel, but I'm not allowed to grieve for my dead child because my live child, and no one will let me grieve. And I'm like, I looked at her husband, probably crossing boundary. I'm like, dude, you got to let her grieve. Don't tell her how to feel. And that's what I saw. I saw people telling you how to feel, and you somehow gaslighting yourself into believing you shouldn't feel. And so the lesson of that patient, it was transferred to you. And I decided to take a risk before, and I took a risk with you, and I'm glad I did. And that's my story.
I'm glad you did too. No, thank you for adding that piece. That is like a really critical piece, because that is very much like what I was trying to do, and what was being relayed to me too is look at the silver lining. And it is beautiful, don't get me wrong, but like Dr. Gillespie said, both truths can coexist, and I wasn't allowing myself to grieve the absolute horrific tragedy of the loss of Nate. and the way that he passed as well, right? And what we're going to get into is this concept of post-traumatic growth, right? It's only in this acceptance of suffering and grief. It's only when we don't gaslight ourselves out of grieving that we're able to take the next step forward. And if we don't, right, like what happens is that we're disconnected from ourselves. We're disconnected from our patients. We're disconnected from everyone around us. And that's exactly what was happening to me, but I just didn't realize it until someone told me, Lizzy, this is what's happening. And that's what I did. And for everyone, this looks different. But for me, it was like journaling, it was praying, it was meditating, it was taking time to just enter into the grief, acknowledge the loss, and then move forward. But I had to do that first step first. So that's my story. And I'm going to pass it over to Dr. Piemonte, and we're going to continue to talk about these concepts. Thank you.
Thank you, Lizzy. You'll be hearing from Lizzy and Dr. Gillespie again. I think what is so important about the stories you heard, both Lizzy's and the one Dr. Gillespie told, is that whether it's in your personal life, like Lizzy, or at work, where you're coding to kids, it's really hard, not only to be in medicine, but just to like be alive. And medicine is then saturated with the human condition, with the fragility of life and death. And the unfortunate thing is that medicine, and then I would say by extension, medical training, nursing training, PA training, OT, PT, disengaged care has kind of become normalized. So it's abnormal to hear these stories. And then that kind of carries over into medical training, where it's abnormal to share these kinds of stories. It's what compelled Lizzy to go talk to Dr. Gillespie, because it was odd and refreshing to hear someone share something vulnerable, and you felt like you needed to express gratitude. It's not a new idea. Researchers have been writing about this. So back in the 90s, some psychologists were kind of looking at medicine, and they say many of the practices and assumptions of medicine seek to escape the reality of suffering, usually through denying it, objectifying it, so just looking at lab results or scans, or sentimentalizing it, making it something fluffy or ethereal that we don't really need to talk about. It's easier to kind of deny suffering than to confront it head on. So if any of you have seen me present, you've probably seen this slide. And for those of you who, I know a couple in the room were around for my last Grand Rounds in Omaha, so this will be a bit of a review for you, but you know, it's good stuff, so we're going to review it. So Martha Nussbaum, she is a moral philosopher, and she writes about compassion, and I find her definition and her concepts of compassion really, really compelling, and it's because they're tied to suffering. So she says, compassion requires a sense of one's own vulnerability to misfortune. To respond with compassion, I must be willing to entertain the thought that this suffering person might be me, that this suffering patient could be me or my loved one, that it's impossible to have compassion without looking at suffering. She says, this I'll be unlikely to do if I'm convinced that I'm above the ordinary lot and no ill can befall me. Now, this is tempting in healthcare. You're the professional, they're the patient. They are sick, you are healthy. And so compassion can become difficult when there is a separation between whether or not you believe you could suffer just like they could, or that you are always just one step away from the potential tragedy of becoming a patient yourself. But that is scary and risky and difficult, and it makes sense that we don't often want to look at that. But it makes compassion really, really difficult. So if we look at the etymological root of compassion, we see it's from the Latin. So passion means the suffering of pain. So you hear things like the Passion of the Christ, that's where that term comes from, the suffering of pain. And then com is in union together, in combination. So compassion, it's not feeling bad for someone or having sympathy or even empathy. Compassion really means the suffering of pain together. Now you might say, okay, I guess that makes sense. So I have to tap into my own suffering. Or, you know, Gillespie was able to tap into his own experience with that patient and their family in order to know how to respond to Lizzy. You have to tap into your own suffering to have compassion for someone else. And then you might say, well, Nicole, that's a really, really difficult thing to ask in healthcare because what about compassion fatigue? We hear, among even pre-meds and certainly by the time you're a first year medical student, well, you can't get too connected to patients. It'll be overwhelming. You'll get burnt out. These are really common assumptions that people make, that you just shouldn't be that compassionate because it's going to take a toll on you. When we look at the research that talks about compassion fatigue, what is this? This definition is a reduced capacity for compassion as a consequence of being exhausted from absorbing the suffering of others. On its face, that sounds right. That sounds right. It would be exhausting to totally be taking on the suffering of other people all the time. Now, this is different from burnout. Often these are conflated, but what's going on here? So burnout can affect any professional. So you could be a lawyer or a hedge fund manager or something and be burnt out because you're working too much and you don't get to see your family. That's burnout. But compassion fatigue, at least some scholars will say that this is experienced by professionals who witness the suffering of others. So that's all of you. I would say, there are teachers who maybe see the suffering of their students and they have no control over their family life or whatever that might be. It's not specific to healthcare, but it's very much concentrated in healthcare because you do see the suffering of others all the time. You think of social workers, that's the world therapists, right? Those are the people who can experience what we have been calling compassion fatigue. The issue with compassion fatigue is that it makes you believe compassion is the problem. The way we have conceptualized this, compassion is problematic and is causing harm. Is that the case? So you could even look at, this is from the nursing literature. I took this straight out of an article in nursing literature where they said, it makes no sense to nurses to participate in programs to foster compassion because they believe being too compassionate is the root of their fatigue anyway. They're like, why would I go to compassion training? And it is also kind of like demoralizing to tell any of you that you've got issues with compassion, empathy, and you need to go to like an empathy remediation course or something. That's not what's going on. But it makes sense that if you believe compassion is the problem, why would you try to be more compassionate? That makes no sense. So what's really going on here? If you look at the neuroscience research, it says that compassion does not cause fatigue. Okay, in fact, compassion, or what we talked about is co-feeling, right? Actually inspires action. If you really have compassion for someone, it inspires you to want to do something about it. And then if you are able to do something about it, it energizes you and you feel better about work and less burnt out. Compassion leads to the behaviors that give you meaning, purpose, and value in your work. Compassion reduces burnout. There's research study after research study that shows that it improves health outcomes, quality of life, and resilience among clinicians. I know that you've met a clinician before who has no compassion, or that's your read, right? They don't seem very satisfied in their work. They're not like thriving. So them being shut off has not led to them thriving. It leads to them just going through the motions. Okay. This does not change the fact that you already, even medical trainees, and you, the clinicians in the room, you are fatigued by something. Something is awry. And if it's not compassion, then what is it? I agree with the scholars out there who say this is what is fatiguing healthcare professionals is the inability to effectively respond to suffering, to make good on their compassion. That you are innately and inherently compassionate. And when you can't make good on that compassion, that is what people are exhausted by. Now, there are times when experiences are out of our control. So the 14-month-old baby who died of a traumatic head injury, no one could do anything about that. And that is going to cause pain in obviously the family, but also people like Dr. Gillespie. So there are those circumstances. where you can't make good on your compassion because it's just tragic. I think is really painful, though, is that there are times where you could make good on your compassion, but a lack of resources, a broken healthcare system, not enough time, or a values mismatch from your healthcare organization. Maybe they're focusing on productivity and efficiency, and you want to focus on connecting to patients. That is what is leading to exhaustion and fatigue, because the system doesn't allow you to make good on your inherent compassion. Jessica DeDecker says, we have been frustrated in our efforts to fully experience the cycle of compassion. So I made a little schematic to help us unpack what I mean here. And so we will stop confusing the word compassion fatigue for what's going on. So up here, you witness suffering and you inherently experience compassion because you see suffering. And then, do you have the ability to adequately respond? Yes. Well, then this leads to compassionate action. And compassion leads to action that connects us to meaning, to purpose, to each other. Or no, is it the fact that you're fighting a health insurance claim, or you don't have time because you're being asked to do too much? Or you think of COVID, you didn't have access to the PPE you needed, so you couldn't make good on it. This is what leads to what some scholars call empathic distress, or moral injury, or vicarious trauma, or secondary trauma. This is not compassion fatigue. This is something else. Because the compassion didn't fatigue you, it just happened. So compassion fatigue, in my view, is a misnomer. That's not what's going on here. It implies that compassion is dangerous and you should stay away from it. And then it implies that there's something wrong with you for having too much compassion. What is wrong with me that I can't just shut it off? Well, you're a human, that's why you can't shut it off. There's nothing wrong with you. There's everything wrong with a broken healthcare system that doesn't allow you to make good on that compassion. The thing that's dangerous about compassion fatigue is that it perpetuates this idea that you should have professional distance. And I hear this and see this all the time. Even with people brand new to medical education or healthcare education, is this idea that I have to remain professionally distanced so that I don't burn myself out. And when we don't engage in this connection, then we have work that feels meaningless and that is just behavioral, right? So when you have that perceived need to feel too much, it has the opposite effect. This is what leads to numbness and feeling nothing at all. Okay? Because turning away from suffering actually increases vicarious suffering because you're not doing anything about it, and feelings of burnout. It ironically has the opposite effect, that self-protection. And it prevents the opportunity for what Lizzy mentioned, which is post-traumatic growth. So we've been using this term, and what is it? Psychologists use this to describe the positive psychological change that happens after really difficult life challenges. You know this kind of intuitively, that it is through suffering that we grow. And this is not like a Pollyanna, naive, silver lining, I'm so glad I went through those terrible things because now I'm growing. I'm so glad that I lost this person I love. No, it's not that. But you know that it is through those challenges that if you're able to articulate them, feel them, process them, you can grow. So what does post-traumatic growth look like? It looks like this increased ability to relate to others. It's exactly what you saw in the story that Dr. Gillespie told, that his experience with that patient and their family then gave him the ability to relate to Lizzy. A gained appreciation for life. You can be more strong emotionally, enhance spirituality, and you might see new possibilities for your life. This is what the literature shows about post-traumatic growth. I like this image of the Japanese art of kintsugi to kind of talk about what happens after trauma. So, when you think about Jake's wife, right?
Nate.
It rhymes. Nate's wife. Okay. So she's rebuilding this life and trying to make sense out of all of this brokenness. And when you've got pottery that breaks and you put it back together, like in kintsugi, it's a totally new amalgamation. It's not the same bowl that it was before. It's totally different. But equally or maybe more beautiful. And what's fascinating about kintsugi is they don't try to cover up the cracks, but they highlight them and they gild them in gold. And so Nate's wife's life is going to look totally different. And maybe something beautiful comes out of it. But pretending that that terrible trauma didn't happen or sentimentalizing it away and covering up the cracks will not lead to post-traumatic growth. It's about seeing a new life in a new way, given all that pain. So it's important to acknowledge that you are affected by your engagement with patients, and there's nothing wrong with you for having those experiences, to feel that pain with patients, and that your responses and feelings and reactions matter. Sometimes we want to dismiss them, that only the patient matters in their experience, but your feelings and reactions matter. In an effort to kind of articulate what you all might have experienced so far, and some of your careers are just in training, but you have had those experiences. I'm bringing Dr. Gillespie up. I want you all to use your cell phone to get that QR code. And Dr. Gillespie is going to explain what you're going to do.
So I think this is the most important lecture you may get in medical school. And she is like so 100% right. When I listen to her speak, I hear 1,000 stories in my head of all the suffering. And what's important is both exist at the same time. What I didn't tell you about this patient is the entire hospital suffered. There was this amazing like group conscience, and a story evolved that the kids weren't in their seats. And I remember, the car seats, and the mom came up to me and she's like, why is everyone telling this lie? Why are they pretending that I didn't protect my kid? I think they're doing that so that they can believe it would never happen to them, and that's your truth. And so what broke me is when I actually got sick, when I was on a ventilator, when I was told I had a 50% chance of dying, when I was told my prognosis is I have a 50% chance of a recurrence and a 50% chance of dying from that recurrence. I remember seeing that on a poster that a medical student put out. But what's important is once you lean into this, and this is what we're going to talk about, I was able to learn that I lost my immortality when I became sick, and I grieved it. And it took me a really long time, and everybody's telling me, look how good you are. Look how good you are. You're so healthy. You're so great. You came back. You're back in the trauma bay. In fact, my partners told me they thought I was never going to practice medicine again. I was so broken. And when I learned that both realities exist, here's the power that Nicole is trying to tell you. Is I took trauma in this city for over 20 years. And one day I walked into the trauma bay and I saw someone suffering and I had no compassion. I don't know what happened. I just saw them rather than someone who's suffering. Oh, but he's like intoxicated. Yes. Why is he intoxicated? Where did that suffering come from? Why is this person in the trauma bay at 2 a.m, having been hit crossing the street, intoxicated? Look at his clothes. How much trauma has this guy been suffering? He's not a trauma in the trauma bay. This is a traumatic life that ended in the trauma bay. That's how I approached every patient. And then one day I didn't have my compassion. I said, okay, I don't want to live with that moral injury. I don't. want to burn out. And so I was able to walk out of that room that night and say, now I'm going to find something I can be compassionate about. And that allowed me to start my elective practice. And I leaned into it. And I'm telling you, every single patient, I break the boundary, the traditional boundary between a patient and a doctor. And my patients love it. And I love it. And so a busy clinic full of 24 patients a day, I come back charged. I'm exhausted, but I'm charged. And so I really want you to understand that this is real and you need to apply this litmus test to your life and figure out, because once you allow yourself to grieve for everything you've lost by entering medicine, okay? Third year is the most traumatic year. Every third year in here was looking for something and didn't get it. And everybody else is telling you, but look, you're in medical school. Look how great you are. You're going to be a doctor. You're going to be one of the most privileged people. You're a nurse. You're a PT. You are one of the most privileged people in the country, in the world. You're the top 1%. That takes away our ability to give ourselves permission to grieve. And if we don't give ourselves permission to grieve, then we lose our compassion. And if we lose our compassion, then why are we doing this? And it becomes meaningless. So what I want to do for you right now is give everybody in this room compassion to grieve. Sorry, I'm giving everyone permission for the ability to grieve without consideration of all the things you're supposed to be happy for, and name it. Name what you're grieving in medicine today in this minute. That one hurts. Somebody has lost the possibility to love. That sounds like hopelessness. That's injustice. Patient suffering causes you to grieve. Yeah, that's real. Oh, I love this one. Uncertainty. Yeah, time, right? The most precious thing we have. I mean, the odds tomorrow we lose every dollar in the bank is low, but the odds that tomorrow we lose the freedom of a life worth living and despair, that's beautiful. You know what I love about this is there's so much diversity. The one that's standing out is patient suffering. We are grieving for our patient suffering, but I think there's as many small numbers as are people in the room. So grief is a very personal thing. A familial connection. I lost mine when I went into training, and then my parents passed away, and I was never able to recapture that. Loss of being the best. Whoever admitted that, that's powerful. A presumed life. Oh man, systemic stagnation. I just had that conversation today with someone. It can break you, that one. Yeah, the distraction of substance abuse and addiction. The loss of naivete. I think that's one of the most powerful ones. I think believing that we were invulnerable. Like, remember how kids think they're invulnerable and immortal, and then when you become an adult, you realize you're going to die. But becoming a doctor or nurse or physical therapist, you realize tomorrow that could be you in the bed, and one day it will be you. You know that for certainty, or someone you love. All right, this is good. Sorry, I was trying to walk out of the room.
These are really, really powerful phrases and words. Thank you for sharing those.
And hopefully you can see yourself in some of these and recognize that if you are feeling your own kind of grief and suffering, that is not happening in isolation. I don't know if that's a good thing, but we're all suffering. Okay, just 1 second. All right. So naming emotions is what's really important. And what happened with Lizzy and Dr. Gillespie is that Dr. Gillespie was able to name those emotions. I give Lizzy just a couple minutes to talk about what that was like, hearing Dr. Gillespie name those emotions for you.
Yeah, I think we kind of initially touched on this, but I love this concept of vulnerability as an invitation. And I think this is like what I want to challenge all of us with. I think it's really, I think being in third year, I've realized just how easy it is to not be vulnerable and to just shut things off and to just continue and just like imitate what everybody else is doing in front of us. And a lot of that time, it's not suffering, it's not grieving, it's not processing. And I just remember watching, I was on the pediatric cardiology floor, and there was this little 6-year-old that coded, and they ended up putting her on ECMO bedside, and it was just like this, there was like this flood of 20 people, and I just remember seeing the dad in the room. And he was just like, his face was just like watching this whole thing play out in horror. He's like, is my little 6-year-old going to survive this or not? Just not even knowing what was going on, just praying, that his daughter's life would be saved. And I was standing next to another medical student. We were watching all of this unfold. And we went and got lunch after that. And he was like, and we were kind of like coming down from that whole experience. And it's really easy to be like, oh, how's shelf studying going? Or how's this or how's that? Like, it's really easy not to talk about the difficult things. And he looked at me and he said, wow, that was really hard. Are you okay? And I just so appreciated that. And it's so simple, right? Like, it's so simple. And it gave me permission again to step into that and enter into this conversation that might not be as comfortable as like something super familiar, like shelf studying. Right. And in the same way, Dr. Gillespie, by sharing his story, by opening up, by asking me, Lizzy, are you okay? Right. It wasn't this big grand thing. Gave me permission, created a space for me to grieve, to process, to open up, to say, no, life is hard and things are hard and this is hard. So it was like really transformative because both of those experiences have really allowed me to do the same for others, but also like be aware of when am I not grieving and when do I need to give myself permission to grieve. So it's really been, I would say, transformative in my whole experience in my medical training and how I treat patients and how I treat my colleagues. Yeah, so I think there's so much power in doing that and just being brave, like in the smallest way for the people around us, whether that's our patients or our colleagues.
So we're going to ask you to be brave, just like Lizzy's describing. So with the person next to you, just share with them what you've not given yourself permission to grieve. It doesn't have to be significant or overly vulnerable, but just allow yourself to express to them, hey, I think that this has been really challenging and I haven't let myself feel it, whether that's in work or outside of work. The listener is going to say back to you what emotions they might be hearing: disappointment, frustration, sadness, grief. And then you'll do the same for them. You'll just switch. So maybe you've been thinking a little bit about what you've been grieving and haven't given yourself an opportunity to grieve. And just with someone near you, share what that is. They'll name your emotions and then you will switch those roles. And then we'll just talk about it for a few minutes.
I'm sorry to interrupt such great conversations. Thank you for being brave. Like that is so scary. And never once, I think in my medical training, did I get asked, hey, look at the person next to you and share something that you're grieving. So I just want to say thank you for doing that. I'm not going to ask you to share the whatever vulnerable thing you shared with the person next to you, but maybe just share about what that process was like, what it was like to talk about and have a space to talk about things like grief and suffering that we don't normally have in this place or in this environment. Any thoughts?
This is a part of the discussion today has been about like the professional boundary and standard. And Dr. Oliver and I were partners. So there's a hierarchy there. There's a professional difference. But it was really meaning. Yeah, it's true. I'm J.O. He's also J.O. He's Jeff. I'm Jeff. I'm J.O. Jr. You can tell. But what was meaningful, it was like the erosion of the professional standard for just a moment, as far as like the connection. And that's something I appreciated through this discussion was that for me, it feels very light. It makes me feel very hopeful that there is humanity left in someone at the end of a career in medicine that I can aspire to. So anyway, that was my experience.
Thank you, Jeff, for sharing. Yes.
Sorry, this just kind of came to mind when you were talking about just like the process. You mentioned that like, and it's been brought up a few times, but just how like we are in a profession that doesn't often facilitate that, and just like doesn't allow people to share their grief. But I think that for me, looking at this, I'm like, okay, it's important to give yourself time to grieve. Like learn to do that personally. But then once you've done so, I think, it's so important to then open it up and begin to change the profession in your immediate circle and begin to create a space that allows other people to grieve as well. So that's just something that just came to mind right there.
That's beautiful. Thank you for
I'm going to try to verbalize this as best as I can, but I think a lot of times in medicine, especially kind of in training, we are taught to be the providers of the silver lining for our patients, try to always, frame conversations in a way where, yes, this is really hard, but, here's what we can do. And these are all the things that, we can provide for you as a clinician. But in a space like this, it's nice to just like commiserate a little bit. It's like, yes, this is my grief. And then have another person say like, yeah, that does suck. Like it's very validating in a way. And, the pressure of, the instinct of, okay, well, this is the bright side. And, this is what you have to look forward to and look at everything that you've accomplished. It's like, no, like, look at everything I gave up and have someone say like, yeah, like that really is a shame. Like that does suck. And I think it's really important to, like you said, like create space for that too, because in some way we do want to just be validated in the way that we feel.
Thanks, Amina. Yes, I'm coming to you, Dylan. Oh, Dr. Siemens coming.
I'm going to call myself out a little bit because I didn't get to go first. And so, because I was still thinking a little bit about what I was going to share. And I could repeat back to you what my partner said, the details and everything, but I wasn't really listening like on that emotional level. And I think I myself and many others get caught up in that of like listening just for the details and not really listening to like the heart part of it. So yeah.
Thanks for your vulnerability and honesty. Any other thoughts? Okay, I'm going to turn it back over to Dr. Piemonte.
Thank you. I think that last statement is really important, right? Because in order to have compassion, you have to have the co-feeling, which is that authentic listening and being able to hear and take in the difficult stuff. I think it's human nature to kind of not want to take that in. And so many of you in this room are very cerebral people, and that's a very comfortable place to be. And then the learning and listening kind of with your heart and the other parts of you can be really challenging. And so I think what you've articulated kind of captures a lot of what people experience. And that temptation, even when you're trying to co-feel with your patients, but you're kind of like, want to focus on the test results and the labs and the images, way easier to talk about that stuff than to talk about the fragility of that person's life, right? In the ways that they suffer. Just want to take a minute or two to kind of summarize what we've talked about today. So what we were trying to do together was to acknowledge the pain and the beauty and wonder of a life in healthcare, because we don't often express that pain. What happens at work affects who you are when you go home, and what happens at home affects who you are at work. So someone on the "What are you grieving" word cloud had said they're grieving their old identity or their personal identity. And I want you to hold on to the fact that it is not that you've got a professional self and a personal self. That is the same person. And if there are terrible things happening in your personal life, it's going to affect how you show up. And that is okay. And compartmentalizing works sometimes, but not all the time. So be who you fully are and that whole range of emotions in every space that you're in. Please remember that your classmates, your coworkers, your colleagues, if you're an educator in this room and you've got students, they're not fragile. You can name emotions to each other and say, wow, it kind of seems like you're struggling this way. You're not going to break that person. They're already feeling all of those things. And remember that people in healthcare are statistically more resilient than people not in healthcare. You're not going to hurt them. So don't be afraid to acknowledge emotions and say them out loud. Normalize, ask about, be present for pain. We want to avoid pain, we do, but you can talk about it. This can be as simple as saying, that was heartbreaking, are you okay? That's what Lizzy told about her conversation with her friend and when they were having lunch, right? That was really hard, are you okay? That's it. This is simple, low-hanging fruit. I get asked this question a lot. What about time? Do we have time to co-feel all over the place and to connect with people? I get it. You are pressed for time for sure, but acknowledging suffering doesn't take that long. The story of Lizzy in the cafeteria, Dr. Gillespie telling Lizzy she needed permission to grieve, these took minutes. It doesn't always take time. Remember that compassion doesn't require you to do more. It requires you to be different. You're doing all the same things, but with a different posture of openness. It is not doing more, it's being different and staying present. And yes, sometimes you do need more time. So we need to continue to advocate for a healthcare system that allows you to have the time that you need to care well for people. This was a quote that we started with, that many of the practices and assumptions of medicine seek to escape the reality of suffering. But I want to remind you what Viktor Frankl said in Man's Search for Meaning. We give our suffering meaning by the way in which we respond to it. It doesn't have to be this way. It can be different. You get to create meaning out of suffering, which will not happen if you turn away from it. It's about looking at it and talking about it. That's all we have for you all. And I just want to thank you for showing up today, not kind of knowing that it was going to be like this, and for really just being amazing conversation partners in this. And feel free to come up and talk to us if you have any other questions. And people on Zoom, thank you all so, so much.